Hello, good afternoon. Right, so let's begin. Exploring the familiar. So, what could be more familiar than clinical anatomy? So, as medical students, as residents, we never really liked anatomy because we had so many things to memorize. But when we see the significance of these things, then we begin to understand them. And with understanding and comprehension, leads to application. So, today, with that in mind, I will discuss the anatomy and histology of the cervix, and I hope I can help you distinguish a normal and abnormal cervix, and to correlate the cervical anatomy with cervical cancer screening and diagnostic and therapeutic procedures. So, screening is a form of secondary prevention. The objective of screening is to detect disease at an early stage, and it targets patients who are asymptomatic or have subclinical disease. These patients have no symptoms, and on physical exam, they appear to be normal. So an example of this, or quintessential example of this, is the Pap smear along with the VIA and HPV test. But there is an assumption when you do the screening test, and that is the cervix appears normal, or at least to the clinician, you're not suspicious of cancer. So let's talk about the anatomy, the normal anatomy of the cervix. So the cervix is a fibromuscular organ that links the uterine cavity to the vagina. In this diagram, you can see that it lies anterior, the bladder lies anterior to it, and the bowel is posterior to it. It is located in close proximity to the ureters laterally. So the blood supply of the cervix is from the internal iliac arteries through the cervical and vaginal branches of the uterine artery. The cervical branches of the uterine artery descend in the lateral aspects of the cervix at the 3 o'clock and at the 9 o'clock position. So when you're a surgeon, you have to be mindful of where these blood vessels are so you do not encounter bleeding when you injure this area. Also, it's important to know these landmarks for devascularization procedures. So the lymphatic drainage is in the parametrial, obturator, internal iliac, external iliac, and common iliac vessels, nodes. Okay, so what is the nerve supply? The nerve supply, it's derived from the hypogastric plexus. The endocervix has extensive sensory nerve endings, whereas there are very few of these endings in the ectocervix. That is why when we perform cervical punch biopsy, it is relatively painless, even cryotherapy or thermal ablation of the cervix, because there are no or minimal pain fibers. So this is different as compared to the endocervix, which have numerous sympathetic and parasympathetic fibers. And this will lead to vasovagal reaction if stimulated. So when we do endocervical curettage, or when we do HSG or sonhysterogram, or even hysteroscopy without anesthesia, it may promote this response. So we have to be careful when we do these procedures. So the cervix has two parts. It has a supravaginal part, or the portia vaginalis, and you have a part that is the portia vaginalis, and it is the portia vaginalis that we are able to see during the speculum exam. And the fornices are the ones anterior or posterior to the cervix. It is bounded by the vagina. So this is the cervix. It is cylindrical in shape, and there is an anterior and a posterior lip. The average length is about 3 to 4 centimeters, and the diameter is about 2.5 centimeters. So when we do our speculum examination, we have to be mindful of the orientation of the uterus. If it's anteverted, we tell our students or our residents that they should point the speculum towards the rectum in a posterior fashion. But if the cervix is oriented, if the uterus is oriented, is retroverted, then we have to be careful about where we place our speculum, because we might traumatize the cervix. And also this occurs when the anatomy is also distorted by a myoma or other structures. Now, for the following slides, I got most, if not all, of the pictures from these textbooks that are available online in digital form, please check out the WHO IARC, the International Agency on Research for Research on Cancer, and you can look at these after the webinar. You can click, you can find the link to that, and you can review the things that I'm saying. So what I did was I just got the pearls and curated them in this presentation. Also, the PSCPC recently had a master class with Professor Basu, who is the author of one of these books, and I will echo the things that I also learned from him. Okay, so let's begin. So we know that the cervix looks different for the nulliparous woman and the multiparous woman. So the nulliparous woman has a smaller cervix and it has a pinhole ectocervical os, as compared to a multigravid who has a fish mouth or a slit, transverse slit of an external os. Okay, so the cervix is composed of a cervical stroma because, as I said, it's a dense fibromuscular tissue. And in this cervical stroma are multiple vascular, lymphatic, and nerve supplies that form plexuses in the stroma. That's why when we do cervical procedures and we penetrate the stroma, we expect some bleeding because it is very vascular. Now, the epithelium lines the cervical stroma, and I will talk about the epithelium next. So when you look at the cervix, this is a typical look of a normal cervix on speculum exam. And this is the ectocervix. And you notice that it is pink, it's smooth, and it's lined by squamous epithelium. Now, the endocervix appears red, granular, and it is lined by columnar epithelium. So you kind of wonder, why, have you ever wondered, why does it look that way? Why is it darker red in the endocervix and then pink in the ectocervix? And this is the reason. So the reason is the ectocervix is lined by multiple layers of squamous cells, but they are transparent. And what you actually see is the reflection of light coming from the stroma, which has several blood vessels. So the red is seen as pink as light passes through these translucent cells and are reflected to your eyes. That's why it's red, because of the blood vessels below. Right. So there are several layers of the squamous epithelium, and we know this from residency. So there's a basement membrane, and the basement membrane and the stroma, the border, the epithelium and stromal border is more or less straight. There are some stromal papillae that protrude, but more or less they're straight, and it is lined by a basal cell layer and a parabasal cell layer, followed by an intermediate cell layer and a superficial cell layer. And as you go up from the basal cell layer to the superficial cell layer, the cells get larger and larger, and the nuclei get smaller and smaller. So what's the significance of that? All right, so let's start with the squamous epithelium. So on the left is a stromal, it's a biopsy. No, it's a biopsy because it has several layers of cells, whereas on the right, that's actually Pap smear. No? So on the superior part of the epithelium are the superficial cells. And you notice that the cells are large, they're flattened, and they have these small pycnotic nuclei, implying that these cells have a large cytoplasm and they have a lot of glycogen. Now, in the second layer, or I would say like in the middle layer, are the intermediate cells. So these cells have a little larger nuclei and a slightly smaller than the superficial cell cytoplasm, but they also contain glycogen. So the superficial cells and the intermediate cells, their maturation is controlled by estrogen, and estrogen causes the glycogenation of these cells. So this is in contrast to the parabasal cells. And the parabasal cells have a larger nuclei, and the cells are round in appearance, and they do not have glycogen. So these cells that do not have glycogen are the cells that you see in menopausal women, so that when you see their pap smears, you see mostly parabasal cells. Okay, so what about the endocervix? So the endocervix, as I said, appears more dark red. And why is that? because it is lined by a single layer of columnar epithelium. So it appears red, then the ectocervix, the ectocervix, because there's only one layer of cells and most of the light is reflected back to your eye. So you can see that it is more red compared to the ectocervix. So enough about the lighting. Now let's talk about the columnar epithelium. So the columnar epithelium, as I said, is just one layer of cells, but unlike the squamous epithelium, it's not like one straight line. It has multiple crypts and it has multiple undulations and multiple folds. So these folds form papillae, and in between these papillae are crypts, and on the edge of these crypts are the crypt openings. So these are not actually glands, but they are crypts. And the crypts, of course, and the columnar cells secrete mucin. Okay, so when you look at it, with this complex architecture of mucosal folds and crypts, it appears as grape-like appearance on visual inspection. Okay, so now we know distinctly what the squamous cells of the ectocervix looks like and what the columnar cells of the endocervix looks like. So we can distinguish them. Okay, so what are endocervical polyps? So endocervical polyps are benign conditions, of course, and these are overgrowths of these columnar epithelium. So they're made of a fibrous core, a stromal core, and then they're lined by columnar epithelium. And sometimes they appear smooth, and sometimes they have squamous metaplasia also. I will talk about squamous metaplasia later on. Okay, so we've talked about the squamous, we've talked about the columnar. So where they meet is the squamo-columnar junction. So the squamo-columnar junction appears as a sharp line with a step. And that is because you see the height of the columnar epithelium is shorter than the squamous epithelium, which has multiple cells. So when you look at it on speculum examination, you can distinguish the two because there's a sharp line that signifies the step from a higher part to a lower part. And the location of this squamo-columnar junction varies in a woman's lifetime. Okay, so it starts in the fetal life. So the original squamo-columnar junction represents the columnar epithelium and the original squamous epithelium laid down during embryogenesis in the intrauterine life. So you can see here that maybe there's a little bit of an eversion because the fetal milieu is affected by the maternal milieu, which is rich in estrogen. Okay, what happens in the prepubertal or premenarche or in childhood? What happens is that the original squamo-columnar junction is still up there. It's small and it's very near the ectocervical os because there's no influence of estrogen yet. But what happens in the post-adolescent period or in the reproductive age? That's when there is eversion. So the cervix gets larger and then the columnar epithelium everts, and thus the columnar epithelium is exposed into the ectocervix. So this condition is a normal physiologic condition, and this is called ectopy or ectropion. Okay, so that now is the new squamo-columnar junction. All right, so what happens to this newly everted columnar epithelium? Squamous metaplasia happens. So squamous metaplasia is a benign process. The word metaplasia means a cell changes from one to another cell. So in this case, the columnar cell in a way changes into a squamous cell. Okay, so what happens? So first, the columnar epithelium everts because of the influence of estrogen. When it is exposed to estrogen, then when the columnar epithelium is exposed to the acidic environment of the vagina, the columnar cells react. Some of them are destroyed, and some of them react in such a way that they start the process of metaplasia. And metaplasia occurs at the periphery of the ectropion, and it goes centrally. So it is the direction is centripetal from the outside going in. So on the left, you see that metaplasia is starting at the periphery of the ectropion, and on the right, we can see that it is fully covered, it is almost fully covered by squamous epithelium, and a new squamocolumnar junction is forming nearer to the external os. Okay, so as this process goes on, the metaplastic epithelium starts to cover the ectropion, and it forms a new squamocolumnar junction nearer and nearer to the endocervical os. And after the completion of the metastatic process, you will have mature metaplasia. So this is the picture on the right, and it shows the new squamocolumnar junction and the old squamocolumnar junction. That one that is outlined in red is sort of no longer seen because the mature metaplasia already blended with the previous squamous epithelium. Right, so what happens microscopically? So microscopically, what happens is this. So the columnar epithelium has proliferation of reserved cells. So if you look at the columnar epithelium, there are reserved cells underneath, and this is activated by exposure to the vaginal milieu. After a while, immature squamous metaplasia is formed, and later on, this develops into mature squamous metaplasia. So metaplasia is not a cancer, it is not a precancer, it is a normal physiologic process that occurs in every woman. Okay, so what are Nabothian cysts? So Nabothian cysts result from the occlusion of the endocervical crypts. So you met the endocervical crypts a while ago, and these are they form because the opening of the crypts are occluded by the metaplastic squamous epithelium. So it appears like sort of like bumps or pimples on the ectocervical portion of the cervix. Mucin fills and distends the cyst, much like a pimple, and you can see fine capillaries which are stretched over them. So sometimes you suspect maybe it's not normal, but when you look at the vessels, they're actually branching vessels that are normal. All right, so what else happens in squamous metaplasia? So as I explained earlier, metaplasia occurs centripetally, meaning from the outside going inside. And sometimes this picture, the arrow, points to occurring squamous metaplasia, and it's pointing like in a tongue, it's a tongue-like appearance because it's showing the direction of the metaplasia from the outside going in. Now, on this part of the screen, this shows the crypts that were left behind by the not completely covered by the squamous metaplasia, as well as islands of columnar epithelium. So these are normal. These are normal findings. And these are also important landmarks to us. Okay, so let's go back to the squamocolumnar junction. So when the woman already is a post-adolescent transformation zone, a new transformation zone is formed. And this is where the old squamocolumnar junction was, with the area between the old and the new squamocolumnar junction that was formed by the squamous metaplasia. Okay, what happens in the postmenopausal period? In the postmenopausal period, this new squamocolumnar junction goes deeper and deeper into the endocervical canal, so it is no longer seen. So you see this in women who are menopausal or have atrophic uterus or cervix. Okay, so this is an example of an atrophic cervix. So you see that it is pale, it has pink appearance, and we know from earlier that what lines this is just a single or a few layers of parabasal cells. And since there's just a very thin layer, it's easily traumatized. So when we put the speculum, it easily forms these petechiae. And additionally, since I mentioned the parabasal cells, they do not contain glycogen also, and they are not because of the lack of estrogen. So the parabasal cells do not mature into intermediate or superficial cells. Okay, so we've talked about the squamocolumnar junction, old and new. So what is the transformation zone? So the transformation zone is a very important area for general OBGYN, for colposcopists, for gyne-onco, and it is marked by the region bounded by the old squamocolumnar junction and the new squamocolumnar junction. Okay, so let's map it out in this speculum examination. So how do you know the borders of the transformation zone based on this picture? So the old transformation zone, or the original squamocolumnar junction, is bounded by the Nabothian Cysts, or the most distal crypts, because that's where the original columnar epithelium was, right? That's what I explained earlier. So this marks the original squamocolumnar junction, and then the new squamocolumnar junction is the one newly formed, and the area bounded by that is called the transformation zone. So in summary, these are the components of the transformation zone. You have the columnar epithelium that changes via squamous metaplasia, and the remaining crypts, and also the Nabothian follicles. So there are different kinds of transformation zones. So type 1 transformation zone is when all of the endocervical component is in the ectocervical part, and it is entirely seen. And that is in situations such as ectropion. So ectropion is a type of type 1 transformation zone. Now, type 2, which is the most common transformation zone, is when part of the endocervical component is in the transformation zone. Part of the transformation zone is seen in the endocervical canal, but it is still visible. And the ectocervical component may be small or large. So most women have this. And sometimes you will have to use a endocervical speculum to be able to see inside. Okay. Lastly, the transformation zone, or type 3, as exemplified by the atrophic cervix. This is when you cannot see the upper limit of the transformation zone because it has already migrated into the endocervical canal. So you wonder, why are we spending so much time on this transformation zone? Why is it important? So the reason is because it is in the transformation zone where HPV infection occurs. So in the new squamocolumnar junction, the HPV, the human papillomavirus, the high-risk oncogenic types, penetrate the basal cells at the new squamocolumnar junction through small abrasions on the surface of the cervix. And over time, this can result in latent infection if it is not cleared. And later on, it enters the productive infection phase. And then finally, this can become a transforming infection, whereas the virus already incorporates itself in the DNA of the cell, and it will progress or lead to premalignancy or cancer. That's why it is important for us to identify the transformation zone, because that is where we have to look for these areas of precancer or cancer. It is also important for us when we perform cryotherapy or LEEP or conization, because we have to assure ourselves that we are able to remove the entire transformation zone, or freeze or burn the entire transformation zone. Okay, so how do we correlate anatomy with the application of acetic acid? So the next speaker will talk about BIA, but I will just explain the pathophysiology regarding this. So dilute acetic acid causes transient reversible coagulation and precipitation of cellular proteins of the cervical epithelium. It also induces dehydration of cells and results in the collapse of the cell membrane around the nucleus. So neoplastic lesions appear white because of the increased amount of cellular protein. So, okay, so this is the normal cervix. So imagine that it is lined by normal squamous epithelium, and then you apply acetic acid. So as I said, the epithelium is translucent, and the cells, the superficial and the intermediate cells, have abundant cytoplasm, so they are not really, and remember that I said that the nuclei are very, very small. So they don't have many, if they're normal, they don't contain any intracellular protein, so there's nothing to coagulate. So when you look at the cervix on after acetic acid application, then it will appear normal because the light will just bounce back through the translucent squamous epithelium. So now this is in contrast to high-grade CIN after application of acetic acid. So with application of acetic acid, the acetic acid coagulates the proteins on these cells, and since there's high content of protein in these abnormal cells, this will appear as white because the light, so the proteins are coagulated by acetic acid, and light cannot pass through this coagulated proteins, and so it appears white. And the more severe the lesion, the more white, the whiter it appears. Okay, so how about the Schiller's or the Lugos iodine test? So the basis for the Lugos iodine test is a chemical reaction between iodine and cellular glycogen. So if the cell contains glycogen, then it will stain with iodine and it will appear black or mahogany brown. So tying everything together, what would appear as mahogany brown? So if they're stained or it is a negative Schiller's test with Lugos iodine, a typical example would be the mature squamous epithelium, because mature squamous epithelium will have glycogen in their large cytoplasms, which was a result of the influence of estrogen, and they will appear as stained with mahogany. So in contrast to the cells with no uptake or with a positive Schiller's test, and these are cells which are exemplified by the immature squamous epithelium. So immature squamous epithelium does not have glycogen, or the columnar epithelium, as I showed earlier, or the atrophic ectocervix that does not have glycogen because there's no more influence of estrogen. Endocervical polyps also don't stain, but if they have some squamous metaplasia on its surface, it may stain. And most importantly, CIN and cancer, because these cells, if you think about it, are more preoccupied about division rather than standing still and accumulating glycogen. So this is just a rundown of colposcopy referrals at the UPPGH Colposcopy Clinic from 2015 to 2020. And there were about 986 referrals. So this center has a fellowship program. So you can see that the fellowship program in colposcopy as well as gyne-onco. So you can see here, let me just move my cursor. Okay. That majority of the referrals were for suspicious cervix. So what does suspicious cervix mean? It means that, okay, it's not an abnormal pap smear. VAA, if it was done, it's not about that. It's the clinician looking at the cervix and saying, there's something different about it. I just can't explain it. The patient has to be referred for colposcopy. So suspicious cervix actually comprise 42% of the referrals. And this is followed by abnormal pap smear and positive VIA and also cancer recurrence, because this is a training center for gynecologic oncology. Now, what were the outcomes of the suspicious cervix? Out of the 341 patients, 70% actually turned out to be just normal. So, but if you look at it, 12% of them, although not quantified as to low-grade or high-grade lesions, were actually CIN. So it means that somehow referrals for suspicious cervix, but you have to hand it to the clinicians also who diagnose patients with suspicious cervix, because there might actually be CIN underneath. Okay. So what are the usual referrals for colposcopy? And I say it here because these are the usual things that are referred to us. So one of them is, most commonly, is Ectropion. So we've met Ectropion several times in this presentation. And as it's the persistence of columnar epithelium on the ectocervix. And as I've shown, it is a normal physiologic condition, but sometimes it is mistaken for ulcer or erosion. So now we know maybe through practice that most of what is thought to be an ulcer erosion is actually just ectopy or ectropion, which is a normal physiologic condition. Now, it is mistaken for erosion. Now, erosion is different from ectropion because erosion is not a physiologic process. It is the peeling off of cervical epithelium, and it appears as a red patch. So this can be due to atrophy because the very thin layer is scratched off and it's torn. As I said, when we have to do speculum exam, we have to be very careful. Or it can be because of inflammation, like little small ulcers due to an infection. Or it can be because of uterine prolapse, like prosidentia, where the cervix is exposed to the outside, where it could have peeling of the ectocervix. Or it could actually be due to HSIL or cancer. So how to tell the difference between erosion from ectropion? Well, ectropion is more common, but if you're not sure, you can't tell the difference between erosion and ectropion, it's okay, just refer to colposcopy because it's better to be safe, especially for our patients. Now, another referral is cervicitis. So sometimes it looks like malignancy. That's not a normal looking cervix. It can be beefy red, but before, maybe you try to reassess first, try to treat the infection first, and then if it's persistently this way, then you refer for colposcopy. Now, how about Nabothian cysts? Now, we talked about this earlier, that Nabothian cysts are just the obstructed crypts of the columnar epithelium, and sometimes the blood vessels are so prominent that people think that it's abnormal vessels because the vessels are very prominent. But how to know if the vessels are abnormal or not? If the vessels are branching, like the branches of a tree, like from large and then they get smaller and smaller and they don't look atypical, then this is just the usual stromal vasculature that is just seen because the mucin is translucent and the vessels are stretched over them. That's why they look more prominent to us. There are also some changes in pregnancy, and changes in pregnancy are a whole webinar altogether. But the most common are ectropion because of the influence of estrogen, mucus plug, and there are some instances of decidual polyps. So decidual polyps are because of overgrowth, again, as the pathophysiology for polyps, but with the influence of increased estrogen. And sometimes it's hard not to distinguish what decidual polyp of pregnancy is and what is cancer. So again, to be sure, refer to colposcopist. Now, this is very different from a picture of invasive cancer. So this is invasive cancer, so different from a normal cervix. So when you see this, the next thing to do here is biopsy. Because as I said, the assumption of screening is the cervix appears normal and you're not suspecting malignancy. Okay, so my take-home messages are that knowledge of anatomy helps the clinician to distinguish between the normal and abnormal cervix, and we have studied the rationale for the screening and the diagnostic procedures for cervical cancer, and these may be explained by anatomy and normal histology of the cervix. Thank you and stay safe.
So good afternoon, and thank you, Meng, for that introduction, and thank you to the organizing committee for this task to talk about the basics of cervical cancer screening, in particular, how to optimize the use of pap smear and visual inspection using acetic acid. So cervical cancer screening has evolved rapidly, with HPV DNA testing now playing an important role in prevention strategies. However, in majority of low to middle income countries like the Philippines, pap smear has remained our integral instrument in the fight against cervical cancer, despite its low sensitivity of about 60%. Others rely on VIA, which is a feasible and affordable alternative method for cervical cancer screening. Several factors limit the test's sensitivity of pap smear, and this false negative rate is largely affected by the interpretation and acquisition or collection of cervical smears. VIA, on the other hand, is very subjective, relying highly on the skill and experience of the test provider. So to address these issues and optimize the utility of pap smear and VIA locally, the contents of this lecture will be the following. My discussion will be based and centered on the most frequently asked questions related to each topic. So let's start with what is the best collecting device to use in performing pap smear. So the evidence related to this topic came from a Cochrane review and meta-analysis of 36 randomized controlled trials and 6 observational comparative studies and 1 recent RCT comparing 3 pap smear collection methods. Both studies compared the commonly used devices for collecting pap smear, which are the spatula with cytobrush, spatula with cotton swab, extended spatula with cytobrush, Cervibrush, and spatula alone. The outcome measured were presence of endocervical cells, adequacy of smears, and detection of dyskaryosis. The design of the collection device may actually influence the adequacy of smears. So in the analysis, inadequate smear was defined as with insufficient cellularity, contamination with blood, menstrual debris, inflammatory cells, or the spread of the smear was too thick. The forest plots presented showed that the pooled estimate for the presence of more adequate smears favored the combination of spatula with cytobrush. On the topic of presence of endocervical cells, this provides evidence that the transformation zone was sampled. Likewise, the presence of endocervical cells correlate with detection of dyskaryosis. Thus, it could be used as a surrogate for the quality of cervical sampling. The forest plots here show more endocervical cells sampled when spatula with cytobrush is used compared with spatula alone, Cervibrush, or spatula with cotton swab. Furthermore, comparison of Cervibrush alone with spatula alone favored the use of Cervibrush to get better smears with endocervical cells. So the devices that were better at collecting endocervical cells also had better adequate smear rates. In terms of correlation of the presence of endocervical cells to detection of cytologic abnormalities, it showed that the devices with better endocervical yield also detected higher incidence of cytologic abnormalities from mild to moderate and even severe dyskaryosis. This recent RCT likewise showed that there was a twofold increase in the number of endocervical cells sampled if the spatula with cytobrush combination was used compared with spatula alone or combination of spatula with cotton swab. Similarly, detection of cytologic abnormalities favored the collecting device that sampled more endocervical cells, that is the combination of your cytobrush and the spatula. So the conclusion for both studies was that the most effective combination in obtaining adequate smears is the use of a cytobrush with an extended tip spatula or Ayer spatula, and the use of extended tip spatula is better for collecting endocervical cells than the Ayer spatula. The rate of endocervical cell detection appears to be a valid and convenient surrogate to detect dyskaryosis and for adequacy of smears. And in developing countries, we can use a cotton swab instead of cytobrush. It may be recommended to improve the percentage of adequate smears. There are limited studies related to sampling devices for liquid-based cytology. So FDA-approved platforms use Cervibrush or spatula with cytobrush as collecting devices. So in the studies that I found, there were variable results as to what is the recommended collecting device. One study showed that cytobrush is superior to Cervibrush as cellular sampling device, while the other study showed that a cervical broom with brush combination was better in sampling endocervical cells and the transformation zone with better detection of cytologic abnormalities. The most recent study on collecting device for liquid-based cytology included 1,200 patients with abnormal cytology. It compared a Cervibrush combi with cytobrush and Ayer spatula. Incidentally, a Cervibrush combi is a Cervibrush or a cervical broom with an endocervical brush feature in the middle. So the results show that the survey brush combi was more effective than the cytobrush with air spatula for endocervical cell sampling and predicting high-grade lesions. So given the evidences presented, the best collecting device is the combination of spatula and the cytobrush. For liquid-based cytology, the plastic spatula with cytobrush and the Cervibrush and Cervibrush combi are recommended. Next question. What are the do's and don'ts in performing cervical cancer screening? Bearing in mind the factors that limit the sensitivity of the pap smear, such as collection and interpretation errors from the effect of blood, debris, and inflammation on adequacy of smears, the patient can be advised about actions that may help enhance the cytology test. So I came across one prospective study that focused on the effects of over-the-counter personal lubricants and antifungal vaginal medications on cytology tests. There were 100 FinPrep vials used from a pool of 270 FinPrep pap test vials, and the results showed that the lubricant with bioadhesive polymer content and the antifungal vaginal medication caused reduction in smear cellularity. And the conclusion was that the potential to interfere with FinPrep tests exists for over-the-counter lubricants and vaginal medications. Now, the evidence related to the effect of menstrual cycle to the performance of cytology tests came from the data of the ALTS trial. Cytology results associated with LMP data in the range of 0 to 28 days were available for 15,000 interpretations. So the data was stratified into 3 periods, early, mid-cycle, and late, reflecting the serum hormone fluctuations during a normal 28-day cycle. So the results show that unsatisfactory smear were noted early in the cycle with an odds ratio of 1.87 than during the mid-cycle. And this was most common during days 0 to 4 of the cycle or during menstruation. However, the authors mentioned that the difference is unlikely to be clinically significant. Now, the HPV viral load was also noted to be highest at mid-cycle when cytology was abnormal, and cytology looked more abnormal when specimens were HPV positive. And the theory behind this is that estrogen interact with adhesion molecules, producing increased deformability and contraction that could facilitate cellular exfoliation. This was also mentioned earlier by Dr. Sikam regarding the effect of estrogen and the ectropion of the cervix. And the levels of immunoglobulins in cervical secretions reach their nadir at mid-cycle, which may favor HPV replication and accumulation to high viral loads. So the conclusion of the study related to cytology result was that mid-cycle specimens yields slightly higher HPV DNA load. It is prudent when possible to schedule screening tests at mid-cycle to optimize the sensitivity and limit the occurrence of unsatisfactory result. Improved understanding of the interactions between hormones and HPV may eventually provide clues that are useful for cancer prevention. I did not find any data related to sexual intercourse, birth control foams, and douching, and the effect of smears. But we may still advise our patients to refrain from using a tampon, birth control foams, jellies, or vaginal creams and vaginal medications, douching, and sexual intercourse 48 hours prior to a test. In our setup of opportunistic screening, pap smear may be performed actually anytime in the menstrual cycle, though it is more prudent to perform the test during the mid-cycle, especially for scheduled visits, all with the intention to optimize the sensitivity of the test and improve adequacy of smear, especially if using the conventional cytology. So the following slides will show the steps to prepare the woman for a pap test or VIA. So part of patient preparation is proper counseling and informed consent. If VIA will be done, a 5% dilute acetic acid is freshly prepared, as moisture during storage may actually cause solution to get diluted easily. So 5 ml of glacial acetic acid is added to 95 ml boiled or distilled water to produce 5% acetic acid. If a pap test will be done, then properly label the slides or the preservative vial before the procedure. Ensure that the woman has emptied her bladder to aid in keeping her comfortable throughout the procedure. Assist her to lie down in a dorsal lithotomy position with her buttocks positioned near the edge of the bed. We have to practice proper hand hygiene and infection control by washing our hands and wearing gloves. Afterwards, switch on the light source and start inspection of the external genitalia. Now we have to choose the most appropriate size speculum to ensure proper visualization of the cervix while maintaining the patient's comfort. Next, lubricate the speculum either with warm water, saline solution, or a small amount of a lubricant gel, but avoiding the tip of the vaginal speculum. Now, will application of these lubricants actually affect the result of the cytology test? So the evidence regarding this issue came from a review and meta-analysis of 7 randomized controlled trials composed of 8,700 women and a cross-sectional study of 83 patients. Both studies concluded that lubricants did not affect or interfere with results of smears of conventional cytology. How about liquid-based cytology? So in a retrospective study by Lin et al. In 2018, lubricants containing carbomer should be avoided when collecting liquid-based pap tests. So these are lubricants that are very thick or very viscous. But lubricants that do not contain these substances do not significantly affect specimen adequacy. Therefore, using of lubricants without carbomers may be used during pap tests. Although I was not able to find a study on VIA, lubricants may also be used during VIA. So afterwards, the speculum is inserted, just like what Dr. Arsica mentioned earlier, gently until the cervix is viewed clearly. Once the cervix is fully visualized, we may now perform the screening test, either pap test or the VIA. So now, how do we collect and fix the specimen for pap smear? Remember that collection and fixation errors contribute to poor interpretation of results. So when using the combination of spatula and cytobrush, take the spatula and use the concave end of the tool. The longer limb of the spatula should be directed to the os. The spatula is then rotated 360 degrees under slight pressure in order to sample the whole transformation zone. The spatula is set aside with the specimen facing up. Take note that the drying out is less if the cell material and the mucus remain in contact with the sampling device. And only after the cytobrush has been used should the material be spread on the slide. Should we use a plastic or a wooden spatula? So wooden and plastic spatulas perform equally well for conventional pap smears, but plastic spatulas are recommended for liquid-based pap smears because cervical cells wash off plastic more easily than wood. So after using the spatula, take the cytobrush and insert it into the endocervical canal. Notice that the junction of the bristles of the brush should approximate the external os as pointed by the blue arrow. Rotate it gently 90 to 180 degrees only, because rotating more does not improve sampling but may cause bleeding. So will sampling sequence affect the quality of smear? So this study showed that the quality of pap smear can be improved by using the air spatula first, followed by the cytobrush, since fewer smears will be contaminated by blood, which may result in more squamous epithelial lesions being detected. So after collecting the specimen, the cytobrush is immediately rolled over the slide in one movement and without pressure so that an even thin smear is obtained. It can be transferred over the outer third of the microscope slide or the central third, or over the other half of the slide. Then the spatula is wiped on the free area again in one movement, not in zigzag pattern, to ensure an even thin smear. So if a cervical broom is used, the long central bristles are inserted into the endocervix. With gentle pressure, the brush is rotated 360 degrees 5 times, rolling the handle clockwise between the thumb and the forefinger. Note that doing a counter rotation will not improve the collection of cells. The sample is then spread on the slide with a painting action using both slides of the brush. So how do we fix the specimen? So the smear must be fixed immediately, and the fixative of choice is 95% ethyl alcohol. The fixative can be from a dropper bottle, or the slide can be placed immediately in a container of fixative that covers the whole cellular area of the slide for 10 minutes. Then it is removed from the fixative and placed dry in a slide box for transportation. A spray fixative can also be used, not the hairspray. by spraying at a right angle from a distance of 20 centimeters with the slide on a flat surface to avoid uneven fixation. Remember that if it is done closer, the cells are blown away. If it on slant, the material is blown in aggregates. Droplet formation is also avoided by not using too much of the fixative. So for liquid-based cytology, it's best to follow the manufacturer's instructions. So for thin prep, the broom is pressed vigorously against the bottom of the vial 15 to 20 times to remove all the cellular material. And the procedure may be repeated if you see residual materials before discarding the broom. While for sure path, the detachable head of the broom with the bristles is removed and dropped into the vial with preservation liquid. The lid is then firmly closed to prevent leakage prior sending to the lab. Now let's look into VIA or visual inspection using acetic acid. So after careful naked eye examination, we gently apply a cotton ball soak with 5% dilute acetic acid to the entire cervix. Take an adequate amount of acetic acid so that a pool of acetic acid is present on the posterior blade of the speculum. Soak the cotton ball in the pool of acetic acid and you can apply it repeatedly on the anterior lip of the cervix, allowing continuous bathing of the cervix using the same cotton ball. Do not rub the cotton ball on the cervix because it may injure the cervical epithelium and induce bleeding. Remember, in high-grade precancers, the surface epithelium can easily get peeled off, leading to erosion and bleeding, as pointed by the blue arrow. So you may also use cotton swabs or spray bottle to apply acetic acid. So while applying the acetic acid, you must check for changes in the epithelium. Columnar epithelium often becomes white immediately after application of acetic acid, but it regains its red color during the procedure. So this is a normal finding. After 1 minute of acetic acid application, proceed to interpret the changes on the cervical epithelium. Remember to keep the cervix moist by repeatedly applying the acetic acid even after 1 minute, because this will aid in better visualization of aceto-white changes. Next, identify and trace the entire squamocolumnar junction. This was beautifully explained by Dr. Asikam. So this is the blue line in the image, and delineate the entire transformation zone, which is shown as the broken red lines on the image. So check for the aceto-white areas, and if present, you must assess for the rapidity of onset, meaning fast or late to appear or disappear, intensity of the color, whether thin or dense. Check if the margin is ill-defined or well-defined, smooth or irregular, whether flat or raised. Note also the number and the location with respect to the transformation zone and the squamocolumnar junction. Check if the surface is smooth or irregular. And lastly, the size of the aceto-white area in terms of number of quadrants occupied or the percentage of cervix involved. Next, how do we interpret the results of visual inspection with acetic acid? So the categories of VIA test outcomes are VIA negative, VIA positive, or suspicious for cancer. So how do we say it's negative, positive, or suspicious for cancer? Remember that not all that turns white is actually cancer. So it is negative when there is no aceto-white area after application of acetic acid. The upper images show that the squamous and columnar epithelium did not show any change in color after acetic acid application. Presence of polyps with faint aceto-white change is also considered negative. A Nabothian cyst that appears white or a columnar epithelium that appears white after acetic acid application and regains its red color is also considered a normal finding. Aceto-white lesions that are far away from the squamocolumnar junction shown in the upper two images are considered insignificant lesions. So as well as patchy or faint aceto-white areas with no sharp margins as pointed by the red arrows are also insignificant. Other insignificant aceto-white lesions are line-like aceto-whitening at the brim of the endocervix, streak-like aceto-whitening or thin aceto-whitening with tongue-shaped projections towards the external os that may represent squamous metaplasia. It is positive when the lesions appear as dense aceto-white changes with well-defined margins near the squamocolumnar junction located in the transformation zone. It may also be seen as dense raised acetowhite changes on the columnar epithelium, which may be an adenocarcinoma in situ. The entire cervix may also appear dense acetowhite. At times, the borders may be hidden underneath the blades, or the inner margin extends to the endocervix. This may represent a high-grade lesion. And a leukoplakia that becomes acetowhite, or when the congenital transformation zone appears acetowhite, these are also considered VIA positive. The presence of a frank growth on the cervix or presence of surface irregularity is already suggestive of cervical cancer, and this is classified as suspicious for cancer. Finally, these three questions may guide you while performing VIA. So the first one is the cervix suspicious for cancer. So if it is, then you may refer or you may do your biopsy. Is the entire squamocolumnar junction visible? If not, then you may refer for help. Is the after application of your acetic acid, is a significant acetowhite lesion visible? If not, then it's VIA negative. If it's yes, then it's VIA positive. Next question. So for average risk women, when do we start screening? How frequent do we perform it? And when do we stop screening? So the answer came from the updated American Cancer Society guidelines. So ACS recommends that individuals with a cervix to initiate screening at age 25. The reason behind this age of initiation is based on the current assessment of the burden of the disease and the balance of benefits and harms, such that the overall burden of cervical cancer among women 20 to 24 years old is relatively small. Though there is high incidence and prevalence of high-risk HPV infection below 25 years old, the rates of persistence and progression are low, and the regression rate is high compared to older age group. This may lead to a potentially high rate of overtreatment and associated harms in women less than 25 years old. Furthermore, screening women at age 21 to 24 has little benefit in reducing the incidence of cancer compared to screening women 25 years old and above. In the supplemental modeling analysis, starting screening with HPV testing at 25 compared to cytology alone at 21 years old, followed by primary HPV testing at 25, retained more than 95% of light year gains with few colposcopies. There was also a 13% gain in cervical cancer prevented and 7% gain in cervical cancer deaths prevented. How about the screening interval? So the ACS recommends that primary HPV testing be done every 5 years. If this is not available, individuals 25 to 65 years old should be screened with co-testing every 5 years or cytology alone every 3 years. So co-testing and cytology are acceptable since HPV testing may be limited in some settings. So this screening interval is based on the microsimulation modeling analysis, where the number of cervical cancer deaths can be reduced from 8.34 for no screening to 0.76 deaths per 1,000 women in women who underwent cytology alone every 3 years at 21 years old. This is further reduced to 0.29 to 0.30 deaths if co-testing or HPV testing every 5 years was done after switching from cytology alone at age 30. Furthermore, there was no difference in the reduction in cumulative cervical cancer rate when cytology alone was done annually versus every 3 years. So when do we stop screening? So ACS recommends to stop screening at 65. So why 65? So the evidence to discontinue screening was based on observational and modeling data and opinion of expert panels. So it was recommended that we stop at 65 if there is no history of CIN2 and above within 25 years, and those with documented adequate negative prior screening in the past 10 years. Adequate negative prior screening is defined as 2 consecutive negative HPV tests or 2 consecutive co-testing or 3 consecutive negative cytology. This is because studies have shown that the prevalence of high-grade lesions was low and cervical cancer was rare in these women with history of routine screening, as well as the benefit to continue screening was low relative to the potential harms associated with screening. Now for VIA, the screening interval for VIA negative average risk woman is every 3 to 5 years. Last question. Is there a benefit in doing pap smear and VIA at the same time? So I found limited data with regards to this topic. First was its influence on normal smear. It showed that acetic acid application before or after a pap test does not influence its result. In this study, they noted 2 patients who had dysplastic smears, which was upgraded after application of acetic acid. But the study on dysplastic cells alone, however, showed that application of acetic acid does not improve the assessment of pap test results. But in this study, a combination of pap smear and VIA increased the screening yield compared to pap smear alone, with improvement of predictive value of negative cytologic screening results. So is there a benefit of doing both tests at the same time? There is no recommendation pertaining to this topic, and the limited data actually does not encourage or discourage doing both tests at the same time. So in summary, remember that false negative pap smear results occur even in well-organized screening programs. So we should maximize the available cervical cancer prevention strategies in our setting to create an impact in cervical cancer elimination. We should enhance the use of pap smear and VIA by choosing the best collecting device, providing good patient preparation, proper collection of specimen, fixation of smears, and application of acetic acid, and by improving our skills in interpreting VIA results. Lastly, know and understand the current recommendation on cervical cancer screening. Let us wait for our local guidelines, which PSCPC, as mentioned, has embarked on. I hope I was able to help you optimize the pap test and VIA. Thank you for listening.
Okay, so it's good to be the last because some parts of my lecture have been touched on by Rennie and Jing, and I hope that those things that I will be repeating will reinforce what they have already told you. So it's Basics of Cervical Cancer Screening, Part 2, and I have no conflict of interest in relation to this lecture, though in one part of the lecture on HPV testing, I will be mentioning product brands, but I am in no way officially connected with any of those. So this is my lecture outline. So the first would be navigating the parts of the pap smear result. So please take note of the color code. So it's teal. So all slides on teal color will be on this topic. So, and then the second one is on the whys and the hows of HPV testing. So that's the pink one. And then the short part on when is colposcopy needed, that's blue. And the last part, a tying up of all of these lectures on VIA, PAP, and HPV test applications in clinical setting. Okay, so first, then navigating the pap smear results. So let me take off from where Jing left off. So she discussed how to do a pap smear. So I'll be talking to you about how to interpret the results. So we will be talking about the 2014 Bethesda system, specimen adequacy, as well as the interpretation of results, but excluding epithelial cell abnormalities, because as mentioned, this will be discussed in the simultaneous session of PSCPC in the actual POGS convention. So the PAP test and Bethesda system, the latest one is 2014, and these authors, Ritu Nair and David C. Wilbur, came up with exploratory notes for Bethesda 2014. I hope to be that explanation to you, short of reading this book, and I don't want to make cytoscreeners and cytopathologists out of you after this lecture. Okay, so this must be small in your screens, but this is just what Bethesda 2014 is all about. So specimen adequacy, interpretation of results, and then on the right side, you have the epithelial cell abnormalities. But for this lecture, I will be concentrating on the left side. Okay, so specimen adequacy. So you have either a satisfactory pap smear or an unsatisfactory. And there are many reasons why a pap smear can be unsatisfactory, including the specimen was rejected because it was not labeled or the slide was broken. So make sure your specimens are labeled and they are not broken. And then there are also reasons why specimens are unsatisfactory, and I will be talking about them later on. Okay, so what are the most important questions as far as specimen adequacy of the pap smear is concerned? It's good that Rennie talked about endocervical cells and transformation zone already. So the first question is, why is specimen adequacy in pap smear important? Because it's the most important quality assurance indicator. For a screening test to be good, there has to be quality assurance. It has to be sensitive enough, but it has to have that quality assurance. The second is, who is it being reported for by the cytopathologists? Of course, it's for the clinicians or those who take the specimen, because it's a good feedback so that we can aim for better specimen collection. And Jing has already told us how to come up with better specimens for our pap smears. The third question is, what makes a pap smear unsatisfactory? And I will be talking about 4 aspects of that. And the last is, how does one manage unsatisfactory smears? And I will be talking about unsatisfactory cytology and those pap smears which have absent or insufficient endocervical cells and transformation cell component. Okay, so the first of the unsatisfactory is the low squamous cellularity. So there is a definition. So there must, remember, pap smear is about exfoliated cells. So there should be a minimum of at least 5,000 well-visualized and well-prepared cells for it to have enough squamous cellularity. But in patients who had undergone radiation for, let's say, cervical cancer or had hysterectomy, this number is goes down to 2,000. So it's important that we have to put these details in our request, whether the patient is cervical cancer patient and had her radiation, or if the patient had the hysterectomy, like say for a high-grade seal lesion, and you are doing pap smear as part and underwent hysterectomy and you're doing pap smear as part of monitoring, you have to mention that so that the cytopathologist would be guided that that is the reason why there's very few squamous cells seen. So the picture actually on your left is, you can see very few cells seen, while the one on the right is actually still very few, as opposed to this one, which have adequate cellularity. Okay. So what is our lesson here? We have to get our samples really well, and we have to provide a short history in our requests. The second one is the EC-TZ component. So what's the definition? No? So the definition of adequate endocervical and transformation cell component is that at least there are 10 well-preserved endocervical or squamous metaplastic cells singly or in clusters. So the picture on the here shows you the endocervical cells and the honeycomb appearance, but this one is side view. So this is the picket fences, while the picture below shows you squamous metaplasia. So as mentioned by Rennie, it's a normal physiologic process. So the presence of endocervical cells and the transformation zone component is actually not part of the adequacy of specimen criteria, but is also a quality assurance indicator, same as cellularity. And you usually do not report it in post-hysterectomy patients. And for if HPV testing will be done, it appears independent of the transformation zone sampling. So doing HPV testing on women where the result of the pap smear showed absent or insufficient endocervical cell or transformation zone component, it's best that they would be HPV tests be performed so as to leave any doubt that there might be some lesions we are actually missing out. But we do the HPV testing only for the ages where these are recommended. And so what are the lessons to learn from this one? We need to get our samples really well. We have to provide, again, a short history in our request, and we can offer HPV testing to those women recommended to have it and have absent endocervical cells and transformation zone component in their pap smears. Okay. What is the third? No? Obscuring factors. So why report obscuring factors as a reason for unsatisfactory pap smear? It's actually for patient care and quality concern. And what's the definition? So you see the picture on the left. This is an unsatisfactory pap smear because of obscuring inflammation. So you practically cannot see the cells anymore, just the white blood cells. So the definition of an unsatisfactory pap smear because of obscuring factors is that more than 75% of the squamous cells are obscured, and there is it's obscured partially if 50 to 75% of the cells are actually not seen. So as a note for cytopathologists, they actually have basis for the 75 or 50% based not on the slide area, but actually on the entire cellularity of the pap smear. And one advantage the liquid-based preparations has is that they are relatively free of obscuring factors because of the centrifuge process. Okay, so the last, interfering substances. Jing touched on this, no? So lubricants, and she mentioned that these lubricants which contain carbomers or carbopolymers, same lubricants that hold our makeup, etc. No, so these ones we do not want to use them because they will appear as granular things under the microscope. But water-based lubricants have no minimal effects, so you can actually use them. And then the other one is excessively bloody specimen. So you can have abundant blood in a thin prep vial, and this might interfere with liquid-based processing, clogging the filter. And the good thing with the liquid-based PAP is it can be reprocessed using diluted glacial acetic acid wash. So glacial acetic acid wash is actually the basis for the VIA, no, of our test. No? So the concentrated version of that is actually can remove the blood in a liquid-based PAP. So again, what are our lessons to learn? Let us avoid lubricants or use water-based ones, and let us avoid taking excessively bloody specimens. Okay. So now, how does one manage unsatisfactory smear? So two areas, no? So unsatisfactory cytology. So the thing to do is repeat the cytology in 2 to 4 months. Treat the atrophy if there is atrophy or obscuring inflammation if the specific infection is noted on the pap smear, and do colposcopy if there are already 2 consecutive unsatisfactory smears, or if there was an HPV testing done and the patient is 30 years or older, then you do colposcopy. And doing high-risk HPV testing after an unsatisfactory cytology as part of triage is not recommended. No? But if there is an HPV testing done already, then it's good to do colposcopy if it turns out to be positive. What about the negative but with absent or insufficient endocervical cells or transformation zone? So as mentioned by Rennie, the transformation zone is a very important area because that's where the HPV infection would start, no? And so what you do with that is, as a preferred next step, is do high-risk HPV testing for women ages 30 or older. But routine screening after 3 years is also acceptable. And if HPV test was done and the result is negative, this patient will go back to routine screening for pap smear. So it's either the usual 3 years testing, no? If there was, with regard to this negative but absent or insufficient endocervical cells or transformation zone. Okay, so now we go to the interpretation of the pap smear results. So we'll discuss briefly non-neoplastic findings, organisms, and endometrial cells. So these are actually the non-neoplastic findings. So non-neoplastic cellular variations, as well as reactive cellular changes, as well as glandular cells post-hysterectomy. So just a quick review, what do they mean, no? So the negative for intraepithelial lesion or malignancy is actually a general category, but squamous metaplasia, keratotic cellular changes, tubal metaplasia are all part of protective mechanism of the cervix, not to noxious stimuli, and they are actually a normal part of the normal repair process. So it's a protection for the cervix, while atrophy is part, of course, of the normal aging phenomenon. It's due to the decreased hormonal support of epithelial tissues, while there could be also pregnancy-related cellular changes due to hormones, and most of these will actually be generally benign. No? So what about the reactive cellular changes? So there could be inflammation, which may involve both squamous and endocervical cells. You can have lymphocytic cervicitis, which is a form of chronic cervicitis resulting in mature lymphoid follicles, but you don't treat it because it's not actually an infection. You can also have reactive cellular changes because of radiation. There could also be reactive cellular changes due to the IUD, and this could either be endometrial or endocervical columnar cells, which can persist for months even with removal. And there's also the glandular cells in a patient with post-hysterectomy, and generally they are, this happens very occasionally, but if they occur, they are usually not a great concern for neoplasia. Some of your patients might ask, now, if you give them the Pap smear result, it's not enough that you would say, ay, okay yan, that's negative. Some of them we really see, why, bakit po may check itong part na to? So at least this is a form of review for you of what to say, no? So these are protective mechanisms, etc. Okay. What about organisms in Pap smear? So you have here the list of organisms which Pap smears would report, no? So is it really part of the reporting? We know that Pap smear is for cervical cancer screening, no? So the Bethesda system generally reports them when identified. So do I treat based on the Pap smear, no? So the thing here is clinical management is dictated in most instances by signs and symptoms rather than the mere presence of the organism, no? So it doesn't mean that if you have a check in one of these, you will already treat. So you have to correlate with the clinical findings of the patient. And how do I regard an organism result in a Pap smear? No, remember again, Pap smear was not intended to diagnose these infections. No, it has a relatively high specificity for this, so that would mean if it's negative, likely there is no disease for that. But it is of low sensitivity. That's why you need a confirmatory test to know whether the patient really has these organisms if they were found on Pap smear. And one more thing, some liquid-based preparations actually use the same specimen for detecting Neisseria gonorrhea, Chlamydia trachomatis, that's the same for the HPV test or for the liquid-based Pap smear. So again, that's another advantage for the liquid-based preparations. Okay, and the last for the navigation of the Pap smear result is the endometrial cells in a woman 45 years or older. The cytopath might report it. Is it normal? No, so it is normal in reproductive age women, especially during menses and the proliferative phase. And as already emphasized by Jing, the best time to collect Pap smears is the mid-cycle because you will avoid this finding already. But it becomes abnormal in the post-menopausal because it raises the possibility of endometrial neoplasia. But then again, you have to remember that the Pap smear was not intended to diagnose an endometrial pathology. So that's why here the 45 is the age to report, no, whether there is the presence of endometrial cells. So again, in the past Bethesda system, it was age 40. It was moved to 45 because this emphasizes the fact that Pap smear is not really intended for endometrial pathology diagnosis. But when it is reported, especially in a patient who is asymptomatic and yet and menopausal, and then with this report, then it's a sign that you have to work up this patient. And a typical endometrial cells are actually found under the epithelial cell abnormalities. Remember, these are the benign endometrial cells that we are referring to here. No? And what are the lessons to learn? So the cytoscreeners in the lab need data from us as to the menstrual cycle and the menopausal status of our patients. So please write the menstrual history, particularly the LNMP. No? And it's also good to find some educational notes. No? So our cytopathologists would put this educational notes in patients with endometrial cells in a woman 45 years or older. So it just tells us that most of these are actually from benign conditions. However, in a postmenopausal woman, again, you have to investigate. Okay. So now we go to the pink part. No? So we now move from Pap smear to HPV testing. So the whys and the hows of HPV testing. So why do HPV testing? So it can be from two perspectives. One is personal. Why do I have to offer HPV testing to my patient? And the other one is from a national perspective. Why incorporate HPV testing in the National Cervical Cancer Screening Program? Okay. So I'll go ahead of what Jing mentioned as the guidelines. So she mentioned about the ACE, American Cancer Society guidelines of 2020, but there is a 2021 WHO recommendation which states that HPV DNA detection is the primary screening test already rather than VIA or cytology in screening and treatment, no? Both among women in the general population and women living with HIV. So why did I devote 15 minutes of my time talking about Pap smear, no? So this is actually a shift in care. It's because if you still don't have an established HPV DNA screening recommendations for your place or for your country, you can still go on doing Pap smear. And for those with already established VIA programs, there is a need to transition gradually to HPV testing as the primary cervical cancer screening tool. Okay, so why HPV testing? So what is the evidence when compared to VIA? So here you talk about prevalent premalignant condition prevalence. So there's a greater reduction with the use of HPV testing in detecting CIN2+. So it's 77 versus 37%. There's also the greater reduction of cervical cancer incidence and mortality. So here, 47.4 versus 58.7% as far as standardized incidence rates. And for mortality, also much decreased for HPV testing compared to VIA. And there's also a decrease in the incidence in stage 2 cervical cancer and higher. So Denny and San Canarayan are very big names as far as cervical cancer screening is concerned. And as a third reason for diagnostic harm, the studies have shown no absolute trend in higher or lower colposcopy referral rates across different studies when you use HPV testing as the primary cervical cancer screening tool. What about HPV testing when compared to cytology or Pap smear? So again, there's an increased detection of premalignant CIN2+ with HPV testing, a decrease in the CIN2+ in the next screening round, and there was cervical cancer risk lowering by 40%. And these were all from real-world cohort studies as well as very good randomized controlled trials. And that is why the WHO came up with this recommendation that HPV DNA test be the screening tool, and this be started at age 30 and done every 5 to 10 years. Okay, so you already have an answer for it's for the WHO, for the general population, average risk woman, 30 years old, when to start, the interval 5 years, and how? By HPV testing. So what is the reason behind that recommendation? So the WHO guideline development group came up with modeling studies. So primary HPV testing every 5 years from ages 30 to 50, regardless of the triaging strategy, because they have many algorithms, resulted in the largest reduction in cervical cancer incidence, more than 50%, and mortality, more than 55%. And you can actually still do VIA testing if you do not have HPV tests in your region, in your area, because it can still reduce cervical cancer incidence by up to 46%, but you have to do it more frequently That's every 3 years. And you have to make sure that there is quality assurance as far as your VI testing is concerned, with a 60% pickup rate of CIN2+. Okay. So sample HPV testing results. So there are many types of commercially available HPV tests. So this is one example. PCR HPV genotyping, reporting for negative HPV 16, 18, and negative for the other high-risk HPV. Well, this is another one. So it tests for 33, 17 of the high-risk types, 16 of the low-risk types. And you can see here, they can actually tell you what specific HPV is positive. Okay? So, are there differences between these tests? No? So that is what I will be discussing now. Okay, so most of my the things I'll be talking about in the next couple of slides came from this very good manual for program managers integrating HPV testing in cervical cancer screening programs, published in 2016 from the CDC, the WHO, and the Pan American Health Organization. So there are many general aspects of the HPV test, and you have to know that there are several types, and you have the direct genome detection as exemplified by hybrid capture 2, but many are actually amplification processes using PCR, polymerase chain reaction. But what I will be talking about are the ones, because there's also RNA-based tests, but we do not have this available in our country, and I think also commercially. So we will be focusing more on the DNA, and these are actually what we have. So hybrid capture 2, COBAS, Expert, and the Asian-based GenoFlow HPV array. Okay, so with regard to the direct genome detection test, which is hybrid capture by DiGene, I would like you to note 8 things. So what is the mechanism? It's actually a probe cocktail for 13 high-risk HPV. These are DNA hybrids identified with RNA probes using a luminometer and a chemiluminescent signal. So that's our light, a positive light makes it a positive result. So who can actually take the samples? Anybody who's trained to take HPV samples can take it. And how is the sampling done? It's similar to what Jing discussed. So use a cervix brush, the combi brush, introduced into the endocervical canal and placed in the tube with medium and transported to the lab. Usually they say 5 to as much as 10 turns to get a sample for HPV. And how is the test process with regard to hybrid capture? It could be manual, it could be semi-automated and you need to wait for 88 samples, or it could be automated and you can have as much as 350 samples. And this is the reason why some of the labs would have this turnaround time longer, because they have to wait for other samples perhaps. And how is the result reported? So it will result a positive for the high-risk HPV if there was light emitted, and negative if no light. So what is the precaution with the test result? For hybrid capture, it cannot identify the specific HPV test, nor whether one or more HPV types are present, because it just slumps up a result of positive for high-risk HPV. And what is its advantage? It is highly sensitive and has a high negative predictive value. So it means that when the test is positive, there is likelihood that the patient actually has a pre-malignant disease or even perhaps early stage cervical cancer. And there is a low probability, if it's negative, if the test is negative, there's low probability that the woman will develop a pre-malignant lesion in the next 5 years. So the disadvantage is the lower specificity and the possible cross-reaction with low-risk types. So this is hybrid capture, the only one with genome direct testing. And then the rest of the tests are actually DNA amplification tests using the polymerase chain reaction. Some would use the L1 as the basis, some would be using the E6, E7, and they have very high sensitivity but very susceptible to contamination. And I will compare Cobas HPV Expert and GenoFlow HPV Array in the next slide. Sorry, this is just a picture showing you the polymerase chain reaction from the target DNA sequence, and then the primer is formed, and then this is replicated, and then this is the cycle goes on and on until there are so many copies of the DNA of the HPV made. Okay, so this is the slide comparing. Sorry if this is coming out small in your screen, but I wanted it to be shown in just one slide. So what's the difference between Cobas by Roche, Expert by Cepheid, and GenoFlow by Diagcore, which is based in Hong Kong, while the two others are based in the USA, no? So Cobas is a throughput system using beta globin gene. So the important thing here, it's using an L1, the L1 part of the protein of HPV. The same with GenoFlow, Diagcore, it's also using L1 but a different primer, while the Expert HPV is actually using the E6, E7 part. So what does it detect? No? So Cobas would detect the 12 high-risk HPV types plus a specific mention of HPV 16 and 18. Well, Gene Expert, the thing here to remember is that it will report to you whether there's positive HPV 16, a positive 18 or 45 in 2 distinct channels, and 11 high-risk types in a pooled result. So that's 11, 12, 13. So 14 types here, 14 types here, but the GenoFlow HPV array reports 33. And as the one I showed you, the picture I showed you earlier with the 33, because it also reports on the low-risk variants plus an important HPV 52, which is very prevalent among Asians. No? So Cobas is fully automated. That's why the advantages it gives us is that there is reduced processing and work time, reduction in error due to fatigue, biohazard waste is also less, and the reagents that are used are also reduced, which can also lead to reduced cost. But of course, the limitations, you really have to train your your medical technologies with regard to the platform, no? And the thing here about Cobas is they have a specific sample preparation. You cannot use another because there are collecting devices which you can use interchangeably between these two, but not for Cobas. Now, with regard to Expert HPV, what I want you to remember is that they have individual cartridges. So they can actually run a sample from 1 to as many as 80. So probably the turnaround time would be shorter. I'm not really sure about that. And with regard to GenoFlow HPV array, so again, I mentioned emphasis on the HPV 52, but with regard to how it's the laboratory processes it's with kit instructions, no, for running the assays in the lab. Okay, so these are the differences between these 3 different HPV DNA amplification tests. So again, going back, so this is actually a Cobas report. This is a Diagcore report. So are there differences between these tests? So from the previous discussion, yes, there are differences. Okay, so we also have to consider their sensitivities and specificities. Remember, these are screening tests, no? And you could see that most of the HPV tests have sensitivities as high as much as 97, 90. Then even Expert HPV here reports 100% based on this study by Kusik, but they have lower specificities. But what we want for a screening test is a higher sensitivity, because if it's a highly sensitive test, then it gives a proportion of women who are positive for the test will actually have the disease. Now, while for GenoFlow array, there is a study which showed concordance with hybrid capture as much as 93% and also higher sensitivities for these abnormal pap smears. Okay, so with regard to cost, so this is another very important consideration. These are estimate costs of hybrid capture. It's actually all of them are beyond 5,000, no? So these are just a range of cost for this test here in the country. What about training? Do we need training for HPV DNA testing? Well, actually, the training is more of how to communicate the information about HPV testing's role in cervical cancer screening, how to take a cervical sample, of course, providing information and counseling to women before and after the test, and appropriately communicating the test results and ensuring that there is follow-up care and these women are triaged accordingly based on the results. And with regard to the procedure for sample collection for HPV DNA testing, so we have 4, no? So preparation. So explain to the woman how it's done and what's the meaning of the results. You also have to perform a gynecologic exam. With regard to sample collection, so you obtain a sample from the cervix with a brush following instructions specific to the collecting device. As I mentioned, COBAS has its own, but the others would have interchangeable collecting devices. Then you place the brush in the collection tube with the preservative solution and label the collection tube with the patient's full name and the date of collection. For post-sample collection, you have to document in the chart that HPV test was done together with other findings, and you instruct the woman about when to return to receive her test results. And with regard to storage and transport, I think this is very important to you. Well, you can store collection tubes at room temperature, so 15 to 30 degrees centigrade. You can transport to the lab and it does not require refrigeration. The tubes can be preserved for 2 to 3 weeks at room temperature. And in the lab, samples can be preserved for an additional week at 4 degrees centigrade and up to 3 months at negative 20 degrees centigrade. And do not use the test after the indicated expiration date. No? So yung sampling devices, collection devices. Okay, so what about managing the HPV DNA test results? So you have 2 algorithms. I chose 2 algorithms out of the 6, no, from the WHO July 2021 guidelines: the screen and treat, and the HPV DNA screen plus colposcopy triage. So what do you do after you tested the patient and she happens to be DNA positive? So if it's negative, you have to rescreen her in 5 to 10 years with another HPV DNA test. While if it's positive, then you determine the eligibility of the patient, whether she can be treated either with ablation, or if it's not, she's not amenable to ablation in the form of, let's say, cryotherapy. Then if she doesn't fulfill the criteria for ablation, then you might have to go for the LEEP or the LETS, or if there is suspicion of cancer, then you have to do your appropriate biopsies. While in the second algorithm, wherein there is HPV, then colposcopy triage. So all those with negative HPV will be rescreened after 5 years, while those with a positive HPV will have to undergo colposcopy. Then this transitions me to the next part of my lecture, which is when is colposcopy needed. So we are now in the blue slides. No? So I actually have only 1 slide for this one. And I captured all the indications, practically all the indications for colposcopy in this slide. No? First, of course, is related to the screening because this is what we are talking about. So an abnormal pap test, so epithelial cell abnormality, except for ASCUS, a positive for high-risk HPV test based on the HPV DNA testing, or evaluation of VIA positive women, or if you have persistent inflammatories but 2 consecutive unsatisfactory cervical cytology would also warrant colposcopy. And then related to symptoms, so women with postcoital or postmenopausal bleeding, even if the pap smear is normal or there's an explained abnormal lower genital tract bleeding, as well as evaluation of persistent abnormal vaginal discharge or vulvar pruritus, then these could be indications also for colposcopy, no, related to symptoms. And the one related to history is that of DES exposure, no, for possible diagnosis of vaginal cancer, and also, of course, as part of treatment and follow-up of maybe subclinical HPV infection, including other genital tract problems, lower genital tract problems like condylomas. No? Conservative management of our intraepithelial neoplasias. as well as identification and management of vaginal extension of our CINs, as well as post-treatment follow-up of our CINs and carcinomas. These are also indications for colposcopy. And the last part, the VIA, the PAP, and the HPV test, applications in the clinical setting. So we are already on the gray slides. So you have to know what is available in my locality or in my place. Is there HPV DNA test? So it needs a platform. You need the collecting devices. Is there Pap smear? Can I do the Pap smear? But then I don't have a cytopathologist to read it. There is VIA. Where am I confident with interpreting VIA results? So it needs training. Of course, colposcopy will also need a machine and training. And then, with regard to your patient, there has to be a shared decision. And this one needs guidance and judgment. So it's actually a shared decision between the patient and the healthcare provider. So here this is you, the healthcare provider. So there are many things that can really determine what you will offer your patient: the knowledge and the skill, the availability in the area, your values and preferences, plus some other factors which are not mentioned here. While on the part of the patient, probably the most important is the cost or the resources. Will doing an HPV test mean her children will not be able to go to school or something, no? Of course, the acceptability and the priorities, values, and preferences of the patients, plus some other factors which probably I wasn't able to mention. But at the end, what you have to come up with is offer the best available screening in the appropriate intervals, considering all the circumstances. And if the best, so we know the best is HPV testing based on the evidences. But if the best is not available, then go for what is next best. But the important thing is that these women get screened regularly. And so last part, no, from the national perspective. So this you might probably cannot read this. These are just the considerations and the processes needed to come up with a national cervical cancer screening program involving HPV DNA testing, no? And these are actually some of the questions. These are not from me. This also came from this book. And perhaps if we would like to venture on following WHO, we can learn from the experiences of not the USA, but maybe Mexico, Argentina, because they are already at this. And what is the roadmap to cervical cancer-free Philippines? This is a slide I showed in a previous lecture. So make the test available. We actually have the HPV test already, but only in selected areas. Make the test affordable, no? 6,000 is not easy for many Filipinos. And then include in UHC guidelines so PhilHealth can cover HPV tests. And lastly, educate the women and make them go for screening, even if we have the structure and the process in place. Of course, that's the first thing that we have to do. And if the clients will not go, then it's nothing. Okay, so I think this is the end of my lecture. So I hope I was able to review you with the results of the Pap smear. I was able to clarify to you the whys and the hows of HPV testing. I have given you a guide on when to do colposcopy or when to refer to a colposcopist. And hopefully I was able to integrate for you VIA, PAP, and HPV. Remember, the next best thing probably after HPV test is a VIA, then Pap smear. Okay, so I didn't know it was World Teachers Day, but I don't know why I picked this cartoon to end this lecture. No, you know what they say, those who don't learn the lessons of history are doomed to go to summer school. So I hope we gave you, all three of us became good teachers this afternoon. So all of you will not go to summer school. Thank you very much.
In order to have a positive pregnancy experience, as the World Health Organization puts it, please appreciate my disclosure. And at this point, I would like to turn off my video for more stable connectivity. Micronutrient deficiency refers to the lack of essential vitamins and minerals required in small amounts for proper growth and development. The 5 important micronutrients required are vitamin A, iodine, iron, zinc, and folate. Maternal nutrient deficiency happens When the pregnant mother persists to have inadequate dietary intake of energy, proteins, essential fatty acids, iron, folate, and other micronutrients during rapid growth phases of pregnancy. Maternal nutrient deficiency is also referred to as hidden hunger, which affects more than 1 in every 4 people. Hidden hunger is currently a global concern as it affects some 2 billion people, majority of whom are women and children, especially those who get pregnant at a young age in the low to middle income countries. Maternal nutrition, rather, accounts for 7% of global disease burden and contributes to a fifth of maternal deaths, with increased probability of poor pregnancy outcomes. It is prevalent in certain areas of the globe where prevalence rate can be as high as 35%. The burden of MND does not end in numerical or geographical figures. More importantly, we must look into its dramatic impact on the health of the mother and the child. After all, we know that poor maternal nutrition status is associated with poor maternal and fetal outcomes. Looking at the 2020 Global Hunger Index, the highest is seen in Africa, followed by South Asia, West Asia, and North Africa, then the East and Southeast Asia, and down the line. Notice that the incidence of adverse pregnancy outcomes, such as mortality, wasting, growth stunting, and undernutrition, is directly proportional to the incidence of Global Hunger Index. The GHI scores incorporates 4 components indicators, namely undernourishment, child wasting, child stunting, and child mortality. Our beloved Philippines currently ranks 69th among 107 countries, and with a score of 19, our local Global Hunger Index classifies us as moderate, at least not serious, alarming, or extremely alarming. The prevalence of nutritionally at-risk pregnant women in our country differs from one region to another, so that the 2016 FNRI figures indicate Mimaropa remains to be the highest, followed by the Western Visayas and Zamboanga Peninsula. The lowest proportion is very evident in the Ilocos region. In 2019, 22.9% of pregnant Filipino women remain to be nutritionally at risk. This challenge is compounded by the rising adolescent fertility and childbearing. Early deficits in fetal and child growth usually stems from inadequate maternal macro and micronutrition before and during pregnancy. To address and manage MND, the topmost in the plan is to identify barriers to proper nutrition. And do you know that hidden hunger is one of them? The others are the lack of knowledge on the importance of prenatal care. Second, the cost of living, so that pregnant women prioritize basic necessities over nutritious foods and pricey prenatals. And third, the limited access to prenatals. Therefore, deficiencies in micronutrients that affect many women of reproductive age are now known to be associated with adverse maternal and perinatal outcomes. These adverse outcomes can have long-term impact on adulthood. And I want you to be reminded of this slide again. As clinicians, we appreciate now from the series of online activities conducted by this company on maternal nutrient deficiency that the effects of MND is multi-organ, if not multi-systemic. That may necessitate multidisciplinary collaboration, and the foregoing statement is clearly depicted in this slide. If we are to categorize the clinical effects of MND when left unattended by age group, then this slide will speak of the issues in details. Maternal nutrient is a must to be supplemented for the important basic reason that it supports maternal health and fetal development. To be comprehensive, the whole process must integrate maternal, placental, and fetal compartments. The supplementation must be continued and consistent. The World Health Organization recommends 1. Enhance the quality of diet by increasing diversity and amounts of food. 2. Promote adequate health weight gain with balanced protein and energy intake. 3. Promote consistent and continued use of fortified foods and food supplements and micronutrient supplementation. Indeed, nutrition education is really very important here. That we, the medical professionals, must be proactive in this role before and during pregnancy. We should emphasize a diet that is balanced, nutrient-based, with limited glycemic load and just enough energy intake. The first 1,000 days reminds us that undernutrition can lead to extensive and irreversible damage to physical growth and brain development and human capital formation. And intervention must be directed to children in the first 1,000 days of life and on women of childbearing age. According to Family Income and Expenditure Survey of 2015, Filipinos consume 159% of recommended consumption of starch staples, particularly rice. For the rest, we are actually falling short. Look at milk there, we are only supplementing 33%. There is an ideal maternal milk brand in the local market that responsibly addresses the need of every pregnant Filipino mother all throughout the 5 trimesters of pregnancy, depending on which organ system is developing and the predominant micronutrients required for such. For instance, the first and second trimesters, when the brain and the body are developing, this maternal milk brand is ideal to address the basic needs of these developments. What makes this ideal maternal milk brand saliently important and different is the fact that it remains to be the only brand in the local market until now that has the power of 3. I'm referring here to DHA, ganglioside, and sialic acid, which synergistically work for optimal brain development and cognition. And regular milk is definitely not enough to address maternal nutrient deficiency. Supplementation to adequately address MND must be an ideal maternal milk brand. It is therefore important at this juncture to introduce the 8 essentials in addressing MND for a positive pregnancy experience. Folic acid at 0.4 mg and iron at 30 to 60 mg daily help in preventing maternal anemia, puerperal sepsis, low birth weight, and preterm birth. Calcium at 1.5 to 2 grams per day supports bone health of the mother and helps reduce preeclampsia, eclampsia, hypertension, and even osteoporosis. Vitamin D is a fat-soluble nutrient that facilitates absorption, metabolism, and maintenance of bone health. Low maternal vitamin D level status is common and enough to be a public health concern. DHA enhances the speed and accuracy of information signals as they travel along the brain cell network. The ideal maternal milk brand is the only one in the local market that contains gangliosides, which works with DHA and sialic acid for optimal brain development. For increased maternal muscle support and renewed energy, protein and amino acid and vitamin B must all be part of the supplementation. To strengthen the immune system, proper cell growth, and disease prevention, the supplement must have the complete complement of vitamin A, C, and zinc. That supplementation must also contain probiotics, which are live bacteria and yeast that might have, after consumption in adequate amount, a positive impact resulting to improved maternal gut health. It should also have prebiotics, which are non-digestible carbohydrates that promote probiotic bacterial growth. The probiotic DR10 is a superior patented strain unique for this ideal milk brand for the mothers. Therefore, complete nutrition is the key to a healthy and positive pregnancy experience. This is a publication that came out in February this year. In this particular publication, it is suggesting that this ideal milk formula can have a This is a recent publication that came out in February that suggests the safety of maternal milk for patients with gestational diabetes mellitus. The ideal milk brand has admitted itself to a research conducted by the Otago University in New Zealand and was found to have low glycemic index that makes it suitable for patients with GDM. Finally, my last slide is on the call to action to eliminate maternal nutrient deficiency. It is the humble intention of this presentation to enjoin all obstetricians and other allied professionals rendering maternal and perinatal health care to seriously address maternal nutrient deficiency through nutrition education and mother's class as part of prenatal care, and to include maternal milk supplementation to provide the 8 essentials for a positive pregnancy experience. Thank you, and these are my references.